in our tradition, I want to start with just a brief part of a poem. This poem is called The Cadaver. It's written by Dr. Alice Jones, and Dr. Jones is both an internist and a psychiatrist. And this poem is actually a 14-page poem, so I'm not going to read except a very brief introduction to the poem, but it's from the book A Life in Medicine, a literary anthology. And if any of you are so interested, that is a magnificent book about the experience of medical training, the experience of being a physician. So, The Cadaver. It starts out by overwhelmed by smell, right? Overwhelmed by smell, warned by this ancient sense, you approach the body cool and supine on the chrome table. This rubbery thing will show you the mysteries as you open his insides. Expose them to fluorescent light and the lab's cold air. Sick of looking, hating the slippery touch that pickles your fingertips into ridges as if you'd been in the tub all day. You fly through the double doors to pace the hard linoleum. Breathe air free of formaldehyde. Feel your separateness in the swing of your arms, your bladder fullness, your blood-pumped warmth. You list your differences from the inert man who teaches you the body's form and names, who teaches you the body's death. So more of Dr. Graney in a little while. It's my distinct pleasure to introduce you to Dr. Jorge Reyes. He is the professor and chief of the Division of Transplant Surgery here at the University of Washington School of Medicine. He's the director of transplant surgery for the Transplant Service. He's the director of transplant surgery as well at Children's Hospital and Regional Medical Center here in Seattle. And he was the former director of pediatric liver and intestinal transplantation at the Children's Hospital of Pittsburgh. He's recognized for developmental strides in areas such as intestinal transplantation, organ allocation, policies, split liver, and living-related transplantation in which the patient receives a section of the liver from a relative. He's a gifted man. We feel very fortunate to have him here at the University of Washington. Would you please welcome Dr. Reyes?
Thank you. I'd like to talk to you about some of the developmental strides in organ transplantation, and then talk a bit about organ donation and transplantation. This is a scientist, it's not me. This is a mouse who has had a piece of skin transplanted onto him. It's probably the simplest model of transplantation. And interestingly, the skin is very immunogenic. It has a lot of the antigens that exist on the surface of your cells that make you who you are, that unfortunately also stimulate the immune system to react. So this is a model that's been used for a long time to study developments of the immune system in transplantation and the development of new drugs. More interestingly, however, the model of skin transplantation actually developed in the mind of a young student during World War II in the bombing of London, where the victims, the burn victims, their wounds were covered with the skin of the victims that had not been burned. And it was his inquisitive mind that realized that some of these skin grafts actually took for a long time or were never rejected. And he began studying the why of that phenomenon. So organ transplantation is really a young field, a little over 50 years. And we can divide it into phases, 1, 2, 3, and 4. The first phase being in the era of the 50s, around the time that Billingham, Brent, and Medawar, these students, were just getting their feet on the ground in terms of research. In those days, the immune system was recognized in terms of defending you against whatever didn't belong to you or wasn't part of you. But people weren't quite sure how to control the immune system. And I have to confess, even today, we're still not absolutely certain. But in the early days, because there were important drugs that were treating cancer, it was felt that these similar drugs could be used to treat these lymphocytes, these cells that we would be trying to destroy because of cancer. We could use similar drugs in order to do transplant procedures. So many of, in this case, this dark rat, transplanted the skin to the white rat, but prior to that, it was important to destroy the cells, the immune cells of this white rat, and then infuse either bone marrow cells or spleen cells from this rat in order to constitute the transplant procedure. So it was basically your basic bone marrow operation together with a skin transplant. And it was important to destroy these immune cells in order to achieve acceptance of this graft and also acceptance of these cells. This situation here we call chimerism, where you have a piece of solid tissue and you also have donor cells in your system. Now, I'm sure that for a long time you felt that when somebody or you've known that when somebody got a heart transplant or a kidney transplant or a liver, they got that organ. Well, they got the organ and they also got a lot of donor cells that came with the organ. So when we transplant these organs, when we remove those clamps and allow blood to perfuse these organs, the patient's blood flushes the organs and seeds the entire body with these donor cells, just like the experiments done in the 50s. Except in the 50s, we didn't know that. We know that now, but in the 50s, we did not know that. These experiments actually resulted in the first bone marrow transplant patients that were transplanted successfully. And it was up to us, the scientists, to figure out, well, what is this bone marrow recipient? What is he made of? And why is it successful with him, with the bone marrow recipients and not with the solid organ transplant recipients? So the big push for transplantation was actually done by surgeons, and I'd like to give surgeons credit for that, but not because we knew what we were doing. It's because we were persistent in trying to achieve success. And it was a trial and error endeavor. We would try certain chemotherapeutic drugs, total body radiation, drainage of lymphocytes, all trying to impact the immune system of these patients. And ended up with a very simple immune suppression of azathioprine and prednisone, an anti-metabolite, something that impacts the lymphocytes, the white cells, the immune cells to replicate. It prevents that. And steroids, which you all know is something that you give when anything happens to you. You just get a shot of steroids. So immunosuppression is critical at every stage, even today, for survival, short and long-term survival. Organ preservation, it became obvious during this time that the studies that were done in terms of trying to preserve organs were seminal. I can tell you, for example, that deceased donor transplants, procuring organs from patients that had suffered brain death, the first operations basically involved putting the patient in a tub of ice water to cool them down very quickly. Well, how are we going to cool them down? Let's put them in a tub of ice water. And that's how it was done. A lot of things were trial and error. That was one of them. Tissue matching for bone marrow transplantation was critical. Now, why was it critical? Because when you do a bone marrow transplant, you destroy the patient's immune system. And the reason you're doing that is because these patients are suffering devastating cancers, leukemias, lymphomas. So you need to destroy, in the efforts to destroy the cancer, you end up destroying all of the immune cells. And you have to give new immune cells otherwise, because that patient is defenseless. So in order to do that successfully, you need to match the antigens as closely as possible. The reason for that is if you do not do that, you risk graft versus host disease, which is these new immune cells that are injected into the patient will attack the recipient. In solid organ transplantation, when we put in a liver, we fear rejection of the transplanted organ. But in bone marrow transplantation, we fear rejection of the patient by the new immune system, new immune cells that are being transplanted. Of course, surgical technology, how to do the operation, how to get these sicker and sicker patients through the procedure has always been a very important part of what we do. And then, in the end, we went ahead and did it. We went ahead and did a kidney transplant, went ahead and did a liver and a heart, after, of course, years of study in the lab, looking at both all of these issues, organ preservation, surgical techniques, immunosuppression, how to impact the immune system. What is it about HLA, chimerism, which is that situation of having an organ transplant and also being seeded with these donor cells around your body. That's called chimerism. All of this resulted in important first cases in transplantation. And we realized that a couple of things during this experience, that rejection, when it occurred, was reversible. And that was very important because everybody feared rejection. Well, how are we going to reverse it? Well, the solution to reversing rejection happened in an elevator in Colorado. They had a patient that had rejected, and they were wondering, well, what are we going to give? Well, what do the oncologists give when they want to destroy white cells very quickly? Well, they give high doses of steroids. Well, let's give them high doses. All right, let's give them high doses of steroid. How much do we give? 100 milligrams? 100. That sounds good. How about 500? It sounds better. How about 1,000 milligrams? That sounds even better. With surgeons, more is always better. So we discovered that we could reverse rejection. And also, in some organs, they were inherently tolerogenic. Now, what does that mean, tolerance? Tolerance is the ability to do an organ transplant and eventually get the patient off the immunosuppressive drugs. With bone marrow transplantation, that occurs routinely. With solid organ transplantation, it's rare, but it does occur. The first successful kidney transplants were actually tolerant. Why? Because they were fraternal twins. And they were able to do the transplants and basically be off immunosuppression. They received pre-transplant sublethal total body radiation. There was no bone marrow given, and maintenance immunosuppression was not required. Dr. Murray won the Nobel Prize for this one case. And this is a dog that I always like to put him in my talks because I like dogs. I have dogs. They bark a lot in the mornings, and my neighbors sometimes come and knock on my door because of that. But this dog is very important because in the days when we were doing experimental organ transplantation to discover the treatment for rejection and diagnosing rejection, these dogs had their immunosuppression stopped, and then a biopsy of the liver was performed to study rejection. This dog never rejected. He was like a surprise. Well, he didn't reject. Well, what do we do now? I don't know. He's not rejecting. This is a failed experiment. So well, let's just keep him around. So they kept him as a mascot. He lived for 13 years, ran away a few times, always came back. He never required immunosuppression. Again, in those days, we were trying to succeed with organ transplantation. We weren't trying to prove tolerance. We weren't trying to say we can transplant and take. So he was ignored for years before somebody said, you know what, this happened to a patient. He actually came off from, how is this occurring? It really wasn't expected. And this is how we used to do immunosuppression. These are graphs that show the immunosuppression and over time. And this is the transplant time here, patient on dialysis. And what it shows here is that in the old cases, when you gave just azathioprine, there was an initial reaction and then rejection, and it was controlled with steroids. So this was the routine. This is how it was done. What was interesting is that these patients became tolerant. These patients that received the first kidney transplants under this immunosuppressive regimen eventually came off immunosuppression. We believe at this point that it was this initial response of rejection that allowed them to become tolerant. And experimentally, we know now that in order for anybody to recognize or accept a particular organ as your own, you need to initially react to that organ. And once you react to that organ, somehow delete those clones of cells that are trying to react to that organ. If you don't have that reaction, you will never be tolerant. You will never be able to come off immunosuppression. Over the course of those years, two fields developed: solid organ transplant, bone marrow transplantation. Differences were important. Tissue matching was essential for bone marrow. Why? Because we destroyed the native immune cells of the patient. Patients usually came off immunosuppression, tolerance, and graft-versus-host disease was common in patients that got bone marrow transplant because their own immune system was destroyed. Whereas with solid organ transplantation, we did not destroy their immune system. So graft-versus-host disease, GVHD, was very rare. Organ acceptance was common, but immunosuppression was the rule. You always had to keep a certain level of immunosuppressive drugs. But tissue matching was non-essential. We could even today, if we're really caught in a bind, we'll cross blood barriers to transplant somebody with a liver, for example, or a heart, if they're that sick. So we can cross a lot of barriers with solid organ transplantation. You cannot do that with bone marrow. Then in December of '63, we felt we were getting better with immunosuppression, and we changed the immunosuppressive regimen, giving steroids from the get-go, and then controlling this reaction and avoiding rejection. So our goal was to avoid rejection, and we thought that, well, if we avoid rejection, then our results are going to be better. And that was phase 2. The development of better and better immunosuppressive drugs, trying to avoid that one thing, rejection. Everybody fears rejection. We need to avoid it. This girl was transplanted over 40 years ago, and she received cyclosporin, which was in those days experimental. And she grew up over the course of the next 40 years, and here she is, 40 years later. She's been off immunosuppression for over 30 years. And she was one that came off very easily. We couldn't explain why she came off, but she was a curiosity. Again, we were still trying to succeed with organ transplantation in general, and that was the phase of the '80s, trying to make it successful, trying to make it an accepted operation that we can do day in and day out. Today, for example, here at the University of Washington, we probably do 1 to 2 transplants per day. It's not an unusual event. And that's what occurs basically in the busy centers. And survival improved. The old days, these patients here that got the old azathioprine immunosuppression, we changed it because the initial rejections were so severe in some patients that the transplant failed. So when cyclosporin came along, it improved survival immediately. And then tacrolimus came along, survival improved also immediately. And then we basically thought, well, the more is better. The more immunosuppression you get, the better. So we started doing transplants with multiple agents, prednisone, azathioprine, tacrolimus or cyclosporin, antibody therapy, etc., trying to prevent this initial reaction, and we were successful. The problem with it was that we were too successful. The long-term consequences of immunosuppression can be significant. This child, for example, he was losing his liver to rejection, chronic rejection. As you can see, he's on cyclosporin. So cyclosporin is a drug that causes hirsutism. It makes the face a little hairy and the body a little hairy. In children, that can be very unsightly. And he was on a lot of steroids. You can see from his facies and from his size that he's on a lot of steroids. And again, we were just introducing the new drug, tacrolimus, and we were experimenting. We were doing clinical experimentation, trying to rescue patients that were failing with this particular drug, cyclosporin. And when we put him on the new drug, within 6 months, this is what he looked like. And this was a big surprise. This was probably one of the biggest accidents we ever had, where, he looks different. Why does he look different? Well, because he's on a lot less drug. The drug that we were giving was stronger, but it allowed us to take him off steroids because it was that strong. And it also, long-term, it allowed us to minimize his immunosuppression. So then, that was the first time, that was in the early 90s. That was the first time I realized that the quality of life, the impact on quality of life and the importance it has in survival, particularly for children, is critical. So we learned a lot, and we're now in phase 4. And what's going to happen, 1991 to now? We're in 2006. We believe that going back to the first slides of the little rat with the cells, and et cetera, in the old days, we used to think that we had a transplanted kidney or transplanted bone marrow, and the cells, the immune cells of the patient would try to reject the solid organ, or in the case of bone marrow transplantation, these cells could potentially reject the patient. What we know now is that there are actually 2 populations of cells, almost like the rat experiments, where the organ brings with it a host of new cells, and they interact with the patient's immune cells, and there's a reaction. We believe this reaction is important in the acceptance of organ transplants with less and less drug therapy over time, and in the eventual development of tolerance. It's a theory, but when we brought back many of those patients who had had their transplants, the lady with the German Shepherd, we brought her back and did a skin biopsy, and we found donor cells in her skin. We brought back patients that had had kidney transplants from their relatives 35, 40 years prior, brought them back, did a skin biopsy or a bone marrow biopsy or a biopsy of the intestine. We found donor cells in these patients 40 years after transplantation, and this is when these patients no longer were on immunosuppressive therapy. So we believe that chimerism is important. We believe that this reciprocal reaction of host versus graft, or graft versus host, under the control of immunosuppressive drug therapy can lead to less and less immunosuppression over time with success of the organ transplant. Similarly, with bone marrow transplantation, the graft versus host response is the major response, but there also is a host versus graft. In a patient who gets a bone marrow transplant, we try to destroy the cancer, we try to destroy that bone marrow that's there, all of those cells, but we're really not that 100% successful. There are native cells still present that eventually proliferate and react with the new bone marrow. So at this point in time, we're in an era of solid organ transplantation and cell transplantation. We believe that it can impact the acceptance of organs, and this has led us on to other research in transplantation of taking a solid organ pancreas and dissolving it and taking the cells, the islet cells that produce insulin, to do cell transplantation, infusion of islet cells into a patient, or take a whole piece of liver, dissolve it, and infuse the hepatocytes into patients because they're lacking a certain enzyme or they're dying of fulminant liver disease. Those are all developmental areas in transplantation. And this is a cartoon showing depicting what happens when we unclamp the vessels in the new liver. The cells leave and they seed the lymph nodes and the other tissues in the body. This is a cartoon showing the same cells leaving, going to the blood, then to the lymphoid circulation and lymphoid tissue, and then to the non-lymphoid sites. Interestingly, this can occur in the other direction. Those cells that are locked in those non-lymphoid sites can also turn around and start mobilizing themselves. So it's a constant change. I've had patients that have been off immunosuppression for 10 years. They develop a bad cold, kind of like the one I have right now, and suddenly they reject their organ. They've been off immunosuppression for 10 years, but the viral infection did something to their immune system that eventually precipitated a rejection. So we're in the era of tolerogenic immunosuppression. We want to achieve tolerance. We want to be able to minimize immunosuppression and get patients off immunosuppression. The reason is not just because it sounds like a good idea, but long-term immunosuppression can be very toxic. The tacrolimus and cyclosporin, over a course of 40, 50 years at a certain dose, will destroy your kidneys. And of course, all these drugs can precipitate cardiovascular problems in the long term. And that's why we endeavor to try to take the patients off. So this is what we do at the present time. We give monotherapy. We try to avoid steroids. We give an anti-lymphocyte globulin up front to try to impact the patient's immune system first before the organ goes in. No steroids unless the patient rejects, and then minimize early on, allowing for a reaction which will facilitate tolerance, and then gradually wean patients off immunosuppression. We'd like to have a test that would tell us when patients are off, when we can wean or take somebody off immunosuppression. We don't have that test yet, but we're looking at some tests, special cells, the T regulatory cells. You have your T cells and your B cells. T cells tell the B cells what to do, we thought, but now we think a little different. Antibodies, cytokines, substances that the cells produce to communicate with other cells. The secretions of the grafts themselves, they produce antibodies. And then the antigens that are presented by these grafts. For example, the intestine, we do intestine transplants. The intestine is tremendously more immunogenic than, let's say, a kidney or a heart. The liver, for example, is very tolerogenic. It's almost like a sieve for antibodies and cells. It just takes them all in and takes care of them, addresses them, and then you can tolerate that liver. The liver is actually a very fun organ to transplant. So So this is where we're headed. Before I left Pittsburgh, I had about 60 kids completely off immunosuppression. But it was our best guess. We did these tests. We thought, well, you know, it looks like it's safe, but we were wrong 30% of the time. They had rejection. We had to go back on immunosuppression. And it's impressive the quality of life that changes in these patients that can come off or can go from twice a day to once a day or to every other day. It does change your lifestyle. So it is important. Xenotransplantation, the utilization of animal organs in humans, is something that is undergoing intense study. I won't speak about this at this stage, but it will happen in the next 20 years. Stem cell transplant is what I was talking about, where we will procure the stem cells from a donor, transplant with the solid organ, trying to induce tolerance or acceptance of that organ with very little drug therapy. And then just going to some more practical issues, what are the solid organs that we're transplanting at this time? Heart, lungs, liver, kidneys, pancreas, small intestine, and combinations of these. We can do heart, lung, liver, heart, lung, heart, liver, kidney, pancreas, a whole host of combinations. When we started doing intestine transplantation, it was for patients that had lost their intestine. And they were suffering because they needed nutrition parenterally, intravenously. And we started doing it successfully, so we started getting referrals of all sorts of different diagnoses that I'd never seen even in my medical school days. So as organ replacement becomes more and more successful, we can address the needs of different patients that have a failing liver and a heart, or have a failing heart, but also have insulin-dependent diabetes. So it really has reached an era of complete care, you might say, from the standpoint of organ transplantation. Tissues, skin, bone, cartilage, ligament, tendons, heart valves, and cornea. 90,000 people are currently on the national waiting list. 18 people die every day waiting for an organ transplant. Every 12 minutes, another patient is listed. So there's a tremendous need. This is the different organs and the number of patients listed nationally. For kidney, 64,000, liver, 17,000, et cetera. Almost 90,000 patients. And locally, in our service area, the number of patients that are listed for these various organ transplants. We have one patient listed for an intestine transplant at the Children's Hospital. She's a little baby about this size. So we're waiting to do her transplant. As you can see, the wait list has increased exponentially. The number of transplants performed, however, has remained relatively static because of the relative lack of donors. So there's a tremendous push nationally right now. It's called the Organ Breakthrough Collaborative. We're really pushing towards trying to get more people incorporated into the need for organ transplants. We do transplants after brain death, organ donation after brain death, organs surgically recovered following the determination of death using neurologic criteria. Now, it's important to point out that the diagnosis of brain death, or the terminology brain death, is something that came out of organ transplantation. Prior to organ transplantation, you didn't really need to declare anybody brain dead. Patients were dead when their heart stopped. And interestingly, we're going back to the old definition of cardiac death, where organs can be recovered following the determination of death by cardiopulmonary criteria. In other words, a situation where there's devastating neurologic damage, but the patient does not meet brain death criteria, and the family wants to withdraw support, and there are many situations like that. Once the family has decided to withdraw support, and support is withdrawn, after a period of complete cardiac death, we can procure the organs after we've established that there is cardiac death. The brain death criteria is with the neurologic exam, and it looks at basically at your various levels of cerebral function, cortical function, brainstem function, your more primitive areas. So no response to painful stimuli, your eyes are fixed and dilated, no corneal reflexes. Oculocephalic reflex also already goes down to the base of your brain. Oculovestibular, similarly, cough and gag, apnea trials, all those things go down to the areas of the brain that are more primitive, that basically regulate our basic functions of cardiovascular function and breathing function. So, and this basically means that the patient has suffered brain death. The brain is totally dead. And when we look at an organ donor, we look at the serologies. We want to see the suitability of the organs by testing for the various viruses that can occur with anybody. CMV, for example, 60% of the population is CMV positive. It's something that we need to know, because if the patient would get cytomegalovirus, CMV is a herpes virus, if the patient would get a cytomegalovirus infection post-transplant, it's important to know if the donor was CMV positive in order for us to already start therapy before they get sicker. And we do cultures and we test the urine and the sputum. We want to be sure that we're not transmitting any infectious disease. And then if we're going to do a heart transplant, the cardiac surgeons are going to want to see what the echo looks like. They may want to see what the vessels, the coronary vessels in the heart look like. So we'll do a cardiac catheterization to do an angiogram to see what the heart looks like. The lung surgeons like to actually look into the airway and do a bronchoscopy, make sure that all the airways are clean and free of infection. A liver biopsy, we sometimes ask for a liver biopsy if we're concerned about a positive serology. For example, we will transplant organs from donors that are hepatitis B or C positive, so long as the biopsy does not show hepatitis. Now we'll do it for patients who already have a history of hepatitis B or hepatitis C. So their risk of developing disease is a lot less than somebody who's naive for these viruses. So it's okay to use these organs. And again, we've had to do that over the course of the last 20 years because there aren't enough organs to be transplanted. If the perfect situation really does not exist with an organ donor. There's always something. There's always a caveat. I remember when I was training, the ideal age was, the blue ribbon donor was under 50 years old. Now I'm 51 now, and I think I'm a pretty good donor. So we're working towards expanding that criteria a little bit. So I'm still an ideal donor. There is a regulation, national regulations that oversee organ distribution in this country. Organ distribution is done by location. We're here in the Seattle, the Wyoming region, Wyoming, Montana, Idaho, Hawaii, Alaska. Thank you. And we serve this entire area for patients and for organ donors. And we want to serve our patients by trying to capture as many organs as possible in that region to transplant them. But we'll also accept organs from outside of our region that other programs won't want to use. We'll accept, and if we have somebody of the appropriate severity, medical severity, that would justify using an expanded criteria donor. We always look for matching the blood type, but sometimes we'll cross blood types intentionally. We never want to do it by mistake. You've, of course, heard that case of the heart transplant. That was a mistake. But sometimes we'll do that intentionally because we're so desperate, usually in the setting of liver transplant, we're so desperate that we will do anything to save the patient's life. And then, and again, in those cases where we've done that, most of those patients have done fine, even though we have crossed the blood barrier. There are patients in heart transplantation, for example, if you're a newborn, a very young child, a baby under the age of 1 year, we're using any blood type organ for these little babies because their immune system has not developed enough to have a problem precipitated by crossing the blood-brain barrier. Organ donation process, generally when we do the operation, we procure the thoracic organs first, and then because there's a timeline. So the thoracic heart surgeons, they're always on the edge. So they want to hurry up, and we basically have to fight over the suction and stuff. So we want them out of the OR as soon as possible, basically. So they run off with their lungs and heart, and then we finish getting the abdominal organs. And we can do these various types of organ transplants because embryologically, when we're formed, this is a little embryo, and these are the components that are giving birth to the various intra-abdominal organs. When they start dragging themselves out, to the abdominal and thoracic cavities. They bring with them the vascular cells that will form the blood vessels, the nerve cells that will form the nerves, and they're very defined. Anatomy and its variations are very well defined. But because it's very well defined, we can do these operations on a routine basis. This is the incision that is done where we open the thoracic and abdominal cavities, exposing the thoracic and abdominal organs. We want to expose the aorta and the vena cava. So these are the two, as you can see, the leg veins here. The legs receive these vessels and give these veins and they join up here in the abdomen, and then they accept the vessels of the kidneys and then the liver, and then it goes back to the heart. So we want to expose these vessels because we're going to put cannulas in them, these tubes, and we do dissections of the various organs that we're going to separate to use. We can do that dissection in situ before we take the organs out, or after we've removed the organs, we could separate them in a cool basin. And here is a cannula that's inserted in the aorta. Now through this cannula, we infuse a lot of preservation solutions, cold preservation solutions. And so when that cannula is in, we go up above here just before, we're letting the heart surgeons do their thing up here. Just before we're ready to flush the organs, we go up here and clamp the aorta and then start infusing the cold preservation solutions. And this allows cooling, rapid cooling of all the abdominal organs. So the preservation of organs, which is very critical, is done through rapid cooling and through special preservation solutions that basically slow the process of cell death. And we can do various types of transplants, so using different surgical techniques, again, to separate the liver from the pancreas, from the intestine. We can do multi-organ transplants, which incorporate everything in the abdomen, the liver, the stomach, pancreas, intestine, or separate them to transplant multiple patients with different organs. We can also split a liver, for example, transplant an adult with a big liver, transplant a pediatric patient with the left the smaller piece, or we can do the same operation in a living donor where we take a small segment of the relative or a friend's liver in order to transplant the child, and the patient's own liver will regenerate. We can also reduce the intestine, giving enough intestinal length that will allow the patient to come off TPN. And we can use very small donors, very newborn donors, for example, where this entire composite of organs, this included the liver, stomach, pancreas, duodenum, intestine, basically fit in the palm of the surgeon's hand. And this was for transplantation of a small baby. I'd like to invite to the podium the real heroes. And if it's okay, Nancy, could you come up and Giovanni and Mrs. Jones. These are the two sides of, real stories of the two sides of organ transplantation. This is Giovanni Jones and his mom. This is Nancy Roberts, and I'll ask Nancy to tell you her story.
I'd like to tell you about my son. My son is Kellen Michael Roberts, and he loved to travel. He went to Bali, and a whole village adopted him. He owned a rice field, and he worked out there and it helped support another family. He loved meeting people, learning about their backgrounds, learning new languages. He was fiercely loving and loyal to his sister, his nephew, me, and his friends. He never complained about anything in life. He'd do anything for his sister. He convinced his nephew that he could turn him colors. I won't tell you how. If you're a young man, you'll figure out how he figured it out. Convinced my grandson that he could turn him colors. He would tie things to the fan in the ceiling to see where they'd fling off. He'd lift him up high over the fence to get balls that they hit out of the yard. And he'd treat him like a duck in a shooting gallery, throwing a Nerf ball at him as he ran back and forth. Last year, in March, my son was vacationing in South Dakota. He was visiting a childhood friend. Went to a party, was drinking, got to running around with a friend. I think if they would have gotten in a fight, but my son, they crashed together. My son fell and hit his head. They thought it was no big deal, but the brain bleed was bigger than they thought, and he died. So we raced out there to see him, and when we got there, they had declared him dead. So we, within a half an hour of seeing him and realizing that there was no hope for him, we were approached by the donation agency back in the Midwest. And we agreed to donate. He was gone, he didn't need his organs, and he was a very giving person. He was always giving away his personal effects to people in foreign countries as he would leave. And so Kellen died at age 22. They were able to find recipients for 7 of his organs. He saved 6 people. And we've met the heart recipient. It was a 17-year-old baseball star from Minnesota. And he's back to playing competitive baseball. I've met his mother, actually. We email and write and talk on the phone a lot. And but he hasn't been able to come out because he's back to playing competitive baseball. But my son saved 6 people. And so I volunteer for the Living Legacy organization because I never thought that in the weeks following my son's death, that the words excited and thrilled would be part of my vocabulary. But when we got the information 6 weeks to the day after Cal died, we got in the mail information telling us the different people whose lives he saved. It was just so exciting. And so I want everybody, nobody wants a loved one to die, but there's good to come out of it. So that's the message I want to give you.
Thank you. Giovanni, would you like to tell your story? Or?
Can you start? Giovanni's a little shy. Giovanni was diagnosed at the age of 7 with autoimmune hepatitis, which is a form of liver disease. And what it did was, for some reason, his body rejected his liver. They didn't know why, and they couldn't tell us why. So we took him out to Children's and to the GI clinic, and they fathered him for many, many years. And off and on, he'd go on to the Imuran or the prednisone, the anti-rejection drugs. And that lasted for 8 years. And last October, the doctor, Dr. Christie, had decided that, for 8 years, the drugs had done all that they could do, and there was nothing else that could be done. And so they decided to go ahead and list him. So he was listed, and I believe he went on the list actually December of last year, of 2004. And in January 2005, he came in really sick, and they gave him a blood transfusion. And the blood transfusion kind of seemed to help for many, many months. He did very well. He did much better than he had done in a long, long time. But come about August of last year, he had got I don't know the medical term for it, but he began to take on fluid. And they would give him these drugs to take the fluid off. And it went off the first time, but when he came back in September, he started to build up this fluid again. And for some reason, it wasn't coming off. And so when we went in, he was doing water therapy for his knees. And we went in November 22nd, and he was 127 pounds, which was the biggest he'd ever been. And he's 16, but he's always been small because of the disease. And they decided that, there was something wrong. This fluid needs to be coming off. Well, he had got a bacteria, an infection, and that's why it wasn't coming off. So they aggressively treated him with the Lasix, and in 8 days, he had lost 50 pounds of fluid. And on somewhere in there, that he went in on a Tuesday, the 22nd. That Friday, he was taking his meds, and he began to vomit blood. And that was the first time I'd ever seen that. Totally freaked me out. And that was the beginning. That was sort of like, to me, the beginning of the end they went ahead and they put some bands in his varices to stop the bleeding, but it didn't really help. In and out he was, we went in on the 22nd, we were there for 2 months. So he bled off and on, he stayed in ICU. We thought we had everything under control on the 8th of December. He got to go home, ended up going back on the 11th because he began to vomit the blood again. And it was just critical. He needed a liver. And then that was the first time I started hearing end-stage liver disease. And for any parent, end-stage anything is terrifying. And he went back into ICU, and he stayed in ICU, and it progressively got worse. And one thing I appreciate about Dr. Reyes is they would have these rounds every morning, 9 a.m., they'd have these rounds. And Giovanni was getting sicker and sicker. And when everybody was trying to think of what to do, he'd come in and say, focus. I'm thinking nothing but transplant, transplant, transplant. And so it was like, this kid needs a transplant. There's nothing else that can be done. It had gotten so bad that I learned a lot about the liver. When the liver doesn't function correctly, a lot of things can go wrong. The ammonia levels got really high, and when your ammonia levels get high, you get confused. He woke up one morning, he didn't know where he was, what was going on. The next day after they decided the only way they can do that is to put him on dialysis. They treated him with extreme dialysis to try to bring the ammonia levels down. It got to the point where if he didn't get a liver, it looked like he was just going to be in ICU forever with 7 or 8 lines in his body and on dialysis 24/7. Thursday, the 22nd of December, he began to bleed. He no longer clotted, and he had 7 lines in, and he bled from everywhere. All the lines, his mouth, his nose. If he didn't get a liver right away, eventually he would die. You can't go on like that. And we prayed. That was the only thing got us through that. We prayed and we believed, and if they thought a liver was coming, our ears were wide open. And I tell you, the scariest thing as a parent is knowing that there's absolutely nothing that you can do to help your child. So we waited and we prayed, and Christmas Eve night, they gave us a call, came up to the room and told us that there was a donor liver. And that's all he asked for. He told me, he says, Mom, I prayed and I asked God for a liver on Christmas. He said, that's all I want for Christmas is a liver. And he said, I think that's the most important thing, is that I get this liver for Christmas. And 10 a.m. Christmas morning, they wheeled him in for his liver. And it has been such a wonderful blessing. And you know, donor parents, I applaud you that you can sacrifice that moment. I mean, you can focus yourself that moment in your grief and be willing to give that part of your baby to save another baby. So this has been 2 months. He got his liver Christmas Day, and he is doing wonderful, and we are thankful.
Seeing Giovanni always brightened my day up, and that's what organ transplantation, I think, is about. There's a haiku is a Japanese poem. It's got 4 lines in it, and there's one that was actually used in a movie recently. But the gist of the haiku is, if you spent all of your life looking for the perfect cherry blossom, it would not be a life wasted. So I see what I do, and I see these families, what they go through, and it's a moment. It can come down to a moment, and it can be a lifetime. So I think your children are like cherry blossoms. They will always be blooming. Thank you very much. Do you have any questions for our panel here? Yes.
Are you on any rejection drugs right now?
Yes, 2.
tacrolimus and prednisone.
Yes.
You talked about donor cells and finding them in the tissue sometime later. I was wondering if you could talk about how that process works.
Sure. These donor cells are called passenger cells, passenger leukocytes that come with the graft. And different organs have different volume of these donor cells. The intestine, for example, has the highest number. And they also vary in terms of the types of donor cells. There are some cells, there are leukocytes, macrophages, dendritic cells, all cells with different names that traverse the different tissues in the bloodstream on a regular basis. This is what they do. So when even though we're flushing the organs out at the time of procurement with these preservation solutions, there are cells that don't leave these organs. They will leave, however, when we unclamp. Why that occurs, we don't know. We know that these cells leave and they are replaced by the patient's cells. And there's a propensity of certain cells to go to certain places. We believe that these cells will determine the immunogenicity of a particular graft, like the intestine is a highly immunogenic organ because of the big volume of cells that are transmitted with these organs. What the exact reaction is, interaction with the patient's cells, we don't know that yet either. We know that it's a phenomenon that occurs routinely. It took us 50 years to actually raise an eyebrow and say this is important. We believe that it is facilitating organ acceptance, but we don't know the exact mechanism as to how that occurs.
So there's markers on the cells that you're looking for when you're in the lab looking for these?
Yes, you can go by the HLA markers, or if you've transplanted a woman with male organs, you can actually find the male cells by looking at the Y chromosome.
Is there such thing as partial transplant or matching an organ to maybe transplant? And what I'm saying is, like, if there's a part of the heart that's dysfunctional, can you just take that section off and like match or something of that nature? You know what I'm asking?
Yeah.
Instead of a whole organ transplant, can you
yes, there is.
connect?
But principally the liver. For example, in patients, there are diseases where the liver looks perfectly normal. There's no damage to it, but the patient was born with the lack of a specific enzyme.
Right.
And the lack of this enzyme produces consequences or pathology in the brain or the kidneys or the heart. And if you were able to provide that enzyme, all these changes would be reversible. Now, we'll change a whole liver just for that.
Okay.
But we can do a section of it.
Okay.
For example, we'll just make some space by removing the left side of the patient's liver and transplant a small segment of a donor liver that contains the enzyme.
Okay, the reason I asked is kind of personal, but I saw on there that on you had on the list was about the pancreas, and it didn't show very many people requiring. I mean, there was a population. I know that's serious, but what I'm asking is, and I know the pancreas is a kind of a delicate organ there, but I was just wondering. That's why I'm looking for an answer. That's why.
Well, pancreas transplantation is solid organ is very successful.
Okay.
But we rely on referrals. When your caregiver thinks you're ready for it, then it's time, because there's always a risk to transplantation.
Right.
So the benefit of the transplant has to be in your favor versus the potential risk of the operation.
You have to go by referral. You can't come in as a single person to go through a process of registration.
You could refer yourself, yes.
Okay, thank you.
Yes.
Do you see a difference in the recipient's immune response when you do a single organ transplant as opposed to multiple organ transplants?
Yes, we have. We initially saw that when we were doing combined liver and kidney transplants, where the liver protected the kidney from rejection. And then we saw it when we did combined liver and intestine. The liver again protected the intestine from rejection. If you were to receive, for example, a liver transplant from on one, let's say you get a liver transplant first and then you need to get a kidney transplant a few years later, in that situation, the liver would not be protective of that kidney. So that protective effect has to be from the same donor at the same time.
First of all, I would like to say again, thank you for our guest tonight. I knew that Santa Claus had an MD, so very happy to have their story tonight.
Okay.
And there is a huge difference between the people that need an organ and the donor. And it looks like this difference is going bigger and bigger. There's more people that need organs and less people that are able to give compared to the number of people that need organs. In the future, how do you see that we can resolve this problem? Is, for example, stem cell research or what kind of xeno?
Yes, stem cell research, artificial organs, tissue engineering, being able to take a cell from a mouth scraping and create another organ for yourself, things like that. I've seen some very nice examples of that type of engineering. I think that would be up and coming. And then xenotransplantation, the utilization of pig liver, for example, for organ transplantation. That's something that is being pushed very heavily.
Thanks.
So, as you can see, Dr. Reyes does some very important work, so we've got to get him home to recover from his cold.
Thanks, appreciate it.
We're very blessed that he could come and talk, and also, thank you.
Great job.
Thank you.